Welcome to the sixth episode of our podcast series, in which hot topics, including new initiatives and alternative viewpoints on patient engagement within the life sciences sector, will be covered. Though patient engagement is more and more common nowadays, it is absolutely crucial that it is also meaningful and sustainable. With this podcast series, we would like to contribute to achieving that goal. So my name is Roger Legtenberg and I'm a senior partner and co-owner of Advocacy. And today I'm sitting here with Steve Clark, a well-recognized stage 4 cancer patient from the UK who has been living his life with the disease over a period of 10 years so far. And he's also an active patient advocate. So welcome, Steve.
Hi, Roger. Good to speak to you.
It's really great that you're here. We met over a conference in London.
That's right.
And I heard you speaking, and I really came to you right away after the talk and chatted with you, and you are really inspiring. You know, when I heard you talking about what you were doing and what you've been doing in the past. So maybe as a start, can you share a little bit about your personal journey? Where everything started. Also, maybe talk about catalysts and motivations, why you became really active as a patient, and your roles in Bowel Cancer UK, Cancer Research UK, and your own initiatives that you started in 2017.
I have bowel cancer, stage 4 colorectal cancer, but of course that's not who I am. One of the things that I'm very keen to talk about is that I've got very strong connections with my family, very active life, love traveling the world, and since my diagnosis I have continued to travel the world. I'm very pleased to say that with stage 4 cancer, just before we had COVID hit the world, I was walking through the rainforest in Borneo, and so that's something you don't normally picture for stage 4 cancer.
You are a human being.
That's the point, and that's the whole thing. So, but my family and friends are really important to me. You know, I've got lots of hobbies and activities like yoga and that sort of thing. But my background as well, which does shape where I got to in terms of being an advocate and how I do things. I worked in the National Health Service in the UK, so in clinical biochemistry for 7 years, and then for 30 odd years, I worked in the pharma industry in sales. Okay. UK marketing, global strategy, and the part of that for the last 10 years, 15 years, I've been a consultant, so running a consultancy practice, helping and advising pharma. So that was me in the lead up to getting diagnosed, and that does shape partly how I handle the diagnosis, and also what I've done since then with getting involved in things in a different way. A very short story of my cancer journey, because obviously, as you said, it's 10 years, which is a long time for stage 4 colorectal cancer. But right at the very beginning, my diagnosis was very lucky. I had very mild symptoms, just going to the toilet a lot. GPs did some tests on me, and I got diagnosed with cancer. But at the time, when I was diagnosed with a very large primary, it had already spread to my liver and both lungs. So I had 3 mets in my liver and 8 across both lungs. The ones in my lungs grew to about 2 to 3 centimeters each. The primary was also particularly unusual because the normal size of a primary tumor in bowel cancer is about, say, 2.5 centimeters diameter. It's a little ball, and so that's the most common size. Mine was 6.5 centimeters wide and over 20 centimeters long, so it had grown along the bowel wall. So but I was caught just as it was spreading, so growing a lot in my other organs at the point that I was diagnosed. So I was lucky in that respect that if I'd been diagnosed, say, 6 months later, we may not be having this conversation.
Sure.
A different conversation. Yeah. I then went through, so I had urgent surgery to remove the primary. So literally within days of my diagnosis, had abdominal resection, which removed the primary. I then had to wait for 2.5 months to heal before I could start on chemo. I went on to what we call intense chemo for 6 months, and it was a regimen called FOLFIRI plus a drug called bevacizumab. So that was every 2 weeks. I was in the chair having infusions for about 6 hours, 8 hours, and then I had a bottle of chemo attached to me for 2 days afterwards. And that was every 2 weeks. It was an intense phase. And the intention of that was to make it so that the secondaries in my lungs could be operated on, because they were too large to be able to remove. But at the end of my 6 months chemo, we had to cancel the surgery because my liver was clear, my left lung was clear, and I only had 3 little dots in my right lung, which turned out to be scar tissue. So that's what chemo and one of the more modern biological treatments did for me. So it's a marker. I think we talk a lot about the need for all these different aggressive treatments, but actually the traditional approaches do still work, and they do still have a role. Okay. And they always have a role alongside some of the new innovations. So that 6 months of intense chemo following surgery got me sorted. And then again, we're talking. So I was diagnosed in May 2013. So come the end of 2013, that was when my intense chemo finished, and my oncologist, who I've got a very good relationship with, same oncologist is still looking after me now, and he said, look, because of the type I've got, it's called KRAS mutation, so the genetic profile of the type of tumor that I've got is an aggressive type. It's known to be aggressive. The general stats show that you've got a higher mortality rate with it, higher recurrence rate. So he introduced the idea of what we call maintenance, what he and I call maintenance chemo. Now, 10 years ago, this was almost not heard of. It was a very new concept, especially in colorectal cancer. And so the idea is that I have, if you like, a much lower level of intensity of chemo to control the growth. So just to keep the cancer in check. Yeah. Now, when it was first piloted, this is where we will talk about communication and the importance of communication and that sort of thing. But this was one of the things that got me, because originally when I was told you're going to be on chemo for life, it felt like it was a sentence. It was a negative thing.
Yeah, I can imagine. It's not something you're looking forward to.
No, absolutely. And whereas actually, it's no different than what we do with almost every other disease, because at the moment in medicine, apart from infections, there are very few things that we cure.
Correct.
We don't have the ability. We control them. Diabetes, hypertension, they are deadly. Yeah. But people can live with those diseases by controlling them, and that's where we've started to come to with even advanced cancer. And it's a different mindset, and this is one of the things that we'll come back and talk to a lot during this chat. It's the approach of both the doctor and the patient to living life with the disease. So as opposed to cure or not.
You said just in the sideline. I'm still being treated by the same oncologist, and I have a really good relationship with him, assuming that it's a he. How important is that to you? Having this very strong, I guess, beacon also for you to go back to, in this 10-year history of living with cancer.
Essential, absolutely essential. The two primary people I've had medically looking after me, if you like, are my colorectal surgeon, specialist colorectal surgeon, and my oncologist. And so up until about 3 years ago, the surgeon was still in touch with me. We were doing regular scoping, colonoscopies, etc. Sure. And there were a couple of tweaks that he had to do for me, but I've been discharged from his care now. But my oncologist, by far the most important person. We had to find our way together. You have to work out what your communication is. And I think, and again, this is something
communication is not per se the most strongest point from everybody in healthcare, right?
It's one of the drivers for me. There's a big gap. There's a big need for, especially in oncology, and we'll loop back on this a lot, I think. There's a big need for improvement in communication skills, then judging what the patient needs and how you're going to give it to them. And it's really, really critical. So initially, some of the things that my oncologist didn't work for me. I actually, you heard me do a talk about nocebo effect.
Yeah, which I'll mention. Of course, yeah. I remember that.
it's something that I'm sort of getting a reputation for. So the nocebo effect is basically, everybody knows the placebo effect.
Mm-hmm.
The best known fact in medicine is the placebo effect. Almost anybody on the street knows what the placebo effect is, which is if you think something's going to work or it's going to do you good, it's going to improve you or cure you, it's more likely to be successful.
Yeah.
That's the placebo effect. And I get a lot of patients, I do a lot of interaction with other patients. A number of times I have heard the line, there's no evidence that a positive mindset makes a difference in medicine. And actually, if you want proof, the placebo effect is proof that it's entirely attitude. And because you've seen data, in different diseases, it's anything from 12% to 25, 30% responses to placebo. That's positive mindset.
Yeah.
But what I've noticed over the years, helping other patients, is that mindset does make a difference. And if you're approaching things negatively, then I was seeing people having more problems. And what I'm saying there is, I'm not saying everybody has to be shouting "yay" all the time and bouncing around smiling. It's not toxic positivity. You hear about being negative because of misconceptions and misunderstandings, and that in medicine is really common, because when we become patients, and bear in mind my background, health service.
You have a relevant background that makes it easier for you to grasp everything that comes on your path, right?
And I was scared of chemo. I made so I should say.
I can imagine, by the way, but yeah.
And it's how it goes. So because I approached it negatively, and it was because of misconceptions, and so the opposite of the placebo effect, which I'm a little bit gutted. It was identified in 1961, but nobody talks about it. I thought I'd come across this new idea when I was researching for that presentation earlier this year, and then when I was doing my research, I found it, which in a way was great because it meant I wasn't going crazy. I was talking sense, but it meant that I didn't have a discovery. But the nocebo effect is the opposite of the placebo effect. So if you think something is going to harm you or isn't going to work, that's more likely to be the case.
Yeah.
Now, what I'm now talking, because I've talked about this now for 6 months or so, I've been talking about communication in oncology for 7 years. I've been talking about nocebo effect for six months or so. Where I've come to now is actually it's one of the biggest secrets in medicine, because it's kept from the doctors. I've talked to audiences of hundreds of clinical researchers and specialists. No one has ever heard of the nocebo effect, because it's not taught in medicine. Your background, Roger, I mean, you've been in healthcare for how long now?
22, 23 years now, pretty much, and trained as a biomedical chemist, basically, originally, and did a PhD. I can't remember that I heard myself nocebo before I talked to you or listened to you.
So it's not taught, but it's really important. So what we're campaigning to do now is actually raise the profile of it and what you can do about it. And so one of the things, what I've started to identify is what I've called the nocebo spiral, which is all of the things that pile in on a patient.
It all adds up, isn't it?
That's the point. So it's not one thing or another. And it could be societal pressures. It could be family stories. One of the things with me, a well-meaning friend who'd been through chemo for a different disorder, which had really been tough for him, took me on one side and talked me through his story to try and help me prepare. But his story was completely different. So I was really scared. So even I had the nocebo effect, and where it manifested for me was my first cycle of chemo. I went in really scared. So a friend of mine drove me into the hospital, sat in the chair for about 8 hours that day. When I left with the bottle of chemo attached to me, I practically had to be carried out to the car, got back to the house, went to sleep, had some friends staying over, and they helped me to eat on the night. And then I perked up a little bit. But the next day, I was sitting downstairs on my own and really feeling sick. I was thinking, oh, this is it now. You knew this was coming. Everybody talks about the nausea. You knew this was going to come. This is what's happening. And luckily, I heard myself thinking that. And I thought, hang on a minute, am I doing this? This is the wrong approach. Don't do this.
Why am I doing this to myself?
Why am I thinking this? So I quickly went online and said, what do you do about nausea? And it was, the advice for it, for example, was really simple. It was, don't lie down, because the typical thing, if you feel ill,
you lie down. That's the easy solution that everybody takes, right?
But for nausea, that's exactly the wrong thing, because your stomach's in the way, your esophagus, you will be sick. So actually, it was sit up, or ideally walk around a little bit. Have a bit of toast, have a bit of water, breathe, and I did that, and I started to feel better.
So you started to adapt to the situation that occurred to you in a way, instead of thinking, "Oh, this is really bad," and getting in this negative spiral. Basically, that's what.
Absolutely, and it was exactly, but it was very clear, because what I did pretty much wiped out the nausea. It shows that it was me causing the nausea, not the meds at that point. And so that is nocebo effect.
But, the same with placebo and also with nocebo, I think it's not always happening, of course. And it's not like rocket, it's not a precise science or something like that. So there's a certain element that is placebo effect or nocebo effect. And that makes it probably also difficult to really get that across to the bigger audiences in the end, and to make it more concrete and more quantifiable, right?
But actually having the term for it, because
that's already a good start, right?
That actually the responses, because effectively I've been talking about this part of things for 7 years, but now having the term to use makes it more, and the fact that there is clinical,
it makes it more tangible, isn't it?
Makes it tangible. That's the whole point, and I think that's where it really, really came. So I mentioned I had a really, really good response to chemo. So I created some little mantras. I tried to approach it positively. I write a lot of tips for patients and that sort of thing. One of them is view chemo as your friend, and it's an important thing to consider, because most of us are scared of it. And if you think about it, and actually I'll tell you this from my experience, almost every cancer patient will tell you that generally speaking, apart from if you've got a very large tumour, you may feel some tumour pain. For the most part, you aren't physically aware that you've got this cancer in your body.
Sure.
Generally speaking.
Yeah.
So therefore, the benefit of chemo is very quiet, because it's doing stuff to something that you can't feel and you don't know is there. And you have to wait until you have a scan, because largely the markers don't necessarily give you an accurate view of what's going on in terms of size. So you have to wait to find out. So it's, as I say, the benefits of chemo are generally very quiet. Side effects of chemo are very loud. They're in your face.
So easily the balance goes in the wrong direction.
Exactly.
Right? That's
so I encourage people to, and I encourage them based on my own experience. Obviously, this is placebo effect. It's the welcome your chemo. I always say to them, see it as whatever works for the individual. There isn't any right or wrong. Sure. See it as a friend. See it as a superhero fighting for you. See it as an army going into battle. But it's whatever suits you in terms of your visualization and that approach. But that's how I viewed it. And important. When I got just to finish that, Roger.
Sorry, sure, no worries.
When I got those outstanding scan results at the 6 month mark, where it was like liver was clear, left lung was clear, just little dots in my right lung. I was given a copy of the CT scan report from the radiologist, where it said the cancer has practically disappeared. Those are his words. And I was talking through it. So my oncologist had given me the results. I sat a couple of days later with my chemo nurse. And we were talking through it, and she was obviously delighted. And she said, "You don't see words like this." And she looked at me and she said, "You know why you got these results?" And she said, 50% this was the chemo. 50% it was your attitude. She said, "I see so few people take it on the way you did." And I mentioned that in my first cycle, I had to be carried out practically.
Sure.
Second cycle a bit better. By cycle 4, I was driving myself to and from hospital.
So you completely turned it around in your head and in the way you approached it. Totally. And you just didn't give in, basically.
Obviously, it knocked me about. There were side effects to it. Of course there were. Sure. It's a serious medicine. But by respecting it and planning my cycle around where I knew my low days were going to be, I kept a chemo diary, so I knew where my low days were going to be. By doing that, I was able to, on my middle weekends, on one occasion I went to Spain on holiday with a friend. Another occasion I went to Frankfurt and helped teach yoga. And on another occasion I went to Hoboken, just by New York, for Thanksgiving in America. That's in the middle of intense chemo, and that's entirely an attitudinal thing.
It's fantastic that you were able to do that, I think, and it shows also how important this is. When you're living with a disease, you know, your life doesn't stop, right? In a way. Is that in the end also why you really thought, you know, let me become more active in this field as a patient activist and advocate? Because at Medicum we always say, you know, the only true experts knowing what it is to live with the disease are the ones that are actually having the disease, right? And it can't be the doctors, it can't be the pharma companies, it can't be nurses, and they all have their own perspectives, and they have very valuable information to share every single time, of course. However, the true experts of living with the disease are the patients, their carers, informal carers or caregivers, whatever you want to call it. How do you see that? Is that?
I couldn't agree more. Absolutely, it's right. What I will always say is, I'm not saying that if you approach your treatment positively or not negatively, you will have the journey that I had. You know,
you don't know. That's the point.
But it'll help you to have hopefully a smoother journey.
With it.
So you'll be able to cope with it. One of the lines that the strap line, if you like, for Strive for 5, the program that I run for patients, is living life with stage 4 cancer. And one of the lines that I wrote around it, which was very much to your point, is a diagnosis of stage 4 cancer doesn't have to mean the end of your life. Yeah. It can be the reason to start living it, which is, I think you touched on it there, and it's really, really important.
Yeah, you know, the more I'm working in this field, and I'm now doing, working with at Medicum now for about 4 or 5 years, and before that, even in the rare diseases space, where I did a lot of research with the CRO, I came across so many individuals. Every time they showed me that there is so much more to live for than simply, just having the disease and lying down in the bed and stuff. If you're that fortunate that you can do that, you know, there are also diseases where you don't have a choice in a way. But even, you know, I even know somebody who has ALS and is really severely debilitated, having that, and it's deteriorating. And even now, he's in a wheelchair. He can only speak with a speaking computer. He's doing remarkable things to still do something meaningful for him, for his legacy, and everything else. Those are really important stories to be told, I think, and that's one of the reasons why we have these kind of podcasts. And it's definitely inspiring, I would say.
And just to back up what you're saying there, Roger, for a long time it felt as though I was an outlier. I was an unusual case, but actually now we're seeing with stage 4 cancer, colorectal cancer particularly, but across most types of cancers, that you're seeing more and more people with stage 4 living longer, but not just surviving, they're thriving, they're living fulfilling.
They're living their life, basically.
And we're talking about the fulfilling life. But coming back to your question before about what made me move into advocacy?
Yeah. So what was the real trigger, actually?
There was a bridge, actually. So when I moved on to the maintenance chemotherapy, which some people call palliative chemo, some doctors will call it palliative chemo, but I think there's a negative...
That's a negative association to palliative, in a way, isn't it?
But actually, if you think what we talked about before, most medicine is palliative, non-curative.
I do agree, but I think that the word palliative... That means there's nothing to do anymore than bearing with it, basically. Yeah.
That's why my oncologist and I call it maintenance chemo, or long-term chemo. So when I moved on to my maintenance chemo, I did have a few side effects, and I went onto an online forum from the charity Bowel Cancer UK, and I went on there as a patient and just said, look, I'm on these tablets which are giving me these side effects. Any tips, any recommendations of getting through it? And I found it very supportive. I got some really good tips that made a difference. The detail of that isn't really important here. It's that reaching out to other patients was really helpful. I stayed on that forum, became involved, and became a moderator within a few months. So I was there were a team, about 5 of us, all patients, that moderated the forum to keep it safe for the other patients. As I was moderating it, and that's where I started to get involved in helping other patients.
Sure.
But I also started to become aware of the disparity, the differences in levels of care. Now, it could be, I'm not saying bad doctors doing bad things to patients, but it was language, it was terminology, differences in the types of drugs that were being used, etc. And I started to see all of these differences, especially around the stage 4 disease.
Yeah, but that's where you are focused in a way, right?
And it was that started to make me want to do more. So initially it was with the charity. I did was involved in some projects with them, and I started to look at a bit wider. And so I was involved in the forum for, I think I moderated it for about 5 years or so. But as I was approaching and I got involved in, as I said, lots of projects with them. But as I was approaching my 5-year mark, there's a milestone in cancer care that the 5-year survival is a big magic marker, and especially around around cancer, it's a big deal. I can use this to relate to stats and what stats mean, etc. Because knowing that there are a number of patients that listen to this, when I was diagnosed, after 6 months, despite my outstanding response to chemo, that was when we taught survival rates. What's my prognosis? Because at diagnosis, my oncologist quite rightly said, when I asked him about how long have I got, he said, it's not easy to say now, let's see how you respond to your chemo, which was absolutely the right response. That was the right thing.
It's the right response, but also I just imagining when I would get such a message, I would probably go crazy at that moment because I want to know what I'm fighting for in a way.
But that's where you tweak it to the individual.
Of course.
When he said to me, I want to see how you respond to chemo, and then we can make a judgment. My response was, well, in that case, I'm going to get everything I can out of chemo. Is that I'm going to really attack this. If he'd told me at diagnosis the median survival for my diagnosis was 18 months, I don't know if I'd have had the fight. And that's the difference. And the 5-year survival, when I was diagnosed, was 5 to 7%. Between 5 and 7%. Yeah. The survival rate is still, it's increased a lot. It's 15%. Maybe, depending on the country.
It's still low, but it's 2 to 3 times higher, actually. Yeah.
Well, you've got to remember, so I talk about this to patients a lot. Those stats are not predictors of individual survival.
No.
That's population data. So it's really useful. So what it allows us to do is, using that data, we can compare one country to another and say, this country's got much higher survival rates.
Why is that?
What are they doing right?
Yeah,
and likewise, you can actually do specialist centre to specialist centre. Why is this one better than this one? Share best practice. So there's an aspect of that you can do, and it's very good. But you have to remember, it's retrospective data, so it looks back historically. It's generally data from about 3 years ago, looking not this year's data. They haven't cut this year's data yet, and they won't for a long time.
Yeah.
So it's generally the data from about 3 years ago, looking back historically. And as I say, it shows you population data. It doesn't show the individual, what you will do. Likewise, so that's talking about survival rates. The prognosis is a different thing entirely. So when I spoke to my oncologist, when I'd had those great results, I said, right, how long do you think I've got? He said, I can't see beyond 12 to 18 months from here. So that would have been 2 years to 2.5 years. Every 6 months, I asked him the same question, and he still said 12 to 18 months. So I just kept moving the goalposts back.
Yeah.
Extending it. And the key thing to remember about a prognosis, the two things I'll say in it. First of all, it's an educated guess.
With these kind of diseases that can actually, all of a sudden indeed speed up again, and
nobody knows.
Nobody really knows, yeah.
But again, because a lot of people come to me and say, I've been told I've only got a year. And they're like, I'm going to go spend my money type of thing. It's different reactions to it. But being told that is the response to it. There are different responses. What I would say, the way that I approached it was, that gave me a goal to beat. So 12 to 18 months, okay, that's not a line in the sand that, okay, 12 to 18 months, I stop. It's 12
You are a fighter.
But again, it's mindset. It's how you're going to approach it and that sort of thing. So, but it's prognosis. And so I'd say two things about prognosis. One is that it's an educated guess. And the other is that apart from you as the patient, the person that will be happiest to be proved wrong is the doctor.
Yeah.
They'll be so happy to be wrong on that. And they will work with you to make sure that they are wrong.
Sure.
But they will be as honest, they will always be honest in those assessments. So, and I think it's important to understand. But this again comes back to our conversation about communication. Because if a patient is asked, as you and I used, would have been two very different responses to the same situation. How long have I got? And the answer was either, well, for me, which suited me, was can't tell you at the moment. Let's see how well you respond to chemo. But he would have to go back and say, actually, these are the numbers. But you then have to put them into context.
Yeah.
And that's where I think many doctors fall down.
From your perspective, being a very educated patient now after 10 years of experience and everything that you go through and every activities that you've done with Bowel Cancer UK and other organizations, your own initiative, besides the communication, I think that's a very important element. I couldn't agree more. I think one of the things with communication, I think, not even between patient and doctor, but also between all the stakeholders in our industry that we are also, that we are part of. Communication is everything. Communication is everywhere and at every time and every decision, every thing where we are talking to different people and different stakeholders. And there is always something that can be improved on communication. I think that is maybe the hardest thing to do in life, I would say, to get really good communication going.
And I'd say, Roger, I think in oncology, that's especially true. Because if you look at the last 10 years in cancer, oncology has been so successful because we are getting, the survival rates are increasing phenomenally. The quality
the whole immunotherapies that have been developed and are currently being developed and progress, and improved and stuff. And the combinations between chemo and immunotherapies and stuff. Yeah, they show their value, I think.
And so because of that, I think this is why I think oncology has been hugely successful. It's now got to catch up with itself in terms of its communication skills.
Yeah.
Because actually, first of all, in most countries, Germany is an exception, but in most countries, doctors aren't taught communication skills, which is odd.
In the Netherlands, they are not really being taught communication skills, I think. At least, indirectly they are. And there is more attention to it nowadays, I think, also in med school than before. But I think, communication skills and being really empathic, that is something that is quite a difficult skill to really master.
Something that I'm working on. I'm involved in a big project on that, and I've been talking about this a lot. I mean, you've heard me talk about it. Other things. So that's why in oncology as well, the language of oncology is set up for where we were 15, 20 years ago.
Sure.
Literally.
So there's a long way to go there.
Yeah, we are labelled at diagnosis as curable or incurable.
Yeah.
And many patients are told at diagnosis, you've got cancer, it's incurable.
Yeah.
We don't use those labels in any other diseases. And that's what I'm saying. So there's nuances. I'm not saying don't ever tell patients you can't be cured, or don't tell patients the bad news. You've got to be honest with them. You need
to move in the field. You need to upgrade your communication as well when the field is progressing and things are changing.
Yes.
You shouldn't forget about those kind of terminologies, right?
And that's I think it's important that communication skills have to change across medicine. In oncology particularly, the language and the tone has to be updated, has to come into the modern age. And again, to your point, when you said very early on, you said the people that know best about what it's like to have the disease are the people with the disease. This is an area where working with the patients on what the language should be. And especially with, you mentioned some of these new therapy areas, the new immunotherapies, the new biomarkers, and then you've got the mutations, the wild types, the triple this.
Yep.
And then you've got
It's never an easy name that they choose, huh?
use terrible terminology. Because if you look at the biomarkers that I'm particularly familiar with, like BRAF and KRAS, which in colorectal cancer, classic biomarkers, you're either wild type or mutant. If you're told you're wild type, that sounds terrible, but actually that's normal.
Yeah, but wild type is better than a mutant, I would say.
But if you were told, oh, you're KRAS wild type, you'd look it up, you'd find out that you've got KRAS, and that's it. You'd be, oh God, and that means this. So actually, the language that's applied to these new things, how it's rolled out, is not done well. How the drugs work, how they're used, etc. The whole area around biomarkers, it's wonderful. The advance is incredible, and it's making such a difference for patients. The science is fantastic, and we are seeing big advances, and they're coming through thick and fast, which is fantastic. But we've got to be smart with how that's communicated to the patient. Because I've got
so that's your biggest gap, I would say, from your perspective. Yeah. On what can change from a patient perspective to healthcare, and in particular stage 4 cancers and cancer in general, I would say.
For a long time now, there's been a move towards patient centricity, in inverted commas. And one of the big things was called shared decision making. Shared decision making can never work until communication is improved and the language is improved. Shared decision making is a destination.
Yeah, but I think that is, you're completely right. You can only do shared decision making if there is a mutual understanding of the same thing from the different angles. It doesn't. You don't have to agree per se on the same things, but at least you need to be well understood on what you're talking about together with each other to make a shared decision. I think, yeah. As a last point here, so. Communication is the most important thing from your perspective. Any major other gaps that you see besides what would fall under the umbrella of communication?
Signposting is, we're talking cancer specifically, but actually probably true with many serious diseases. One of the things it links to communication, granted, but this is your communication. If someone is told that they've got a disease, you get home, and one of the first things you do these days is you hit your favorite search engine on the computer. And we always say don't trust Dr. Google, but it's you go on there and you will find out what you can. It's really hard to find the reliable information. Some doctors and nurses will say only go to reliable sites.
How do you know what is a reliable site as a patient? And I think that's an interesting thing that you're raising here, Steve. We are actually quite active in that field in a way that we are trying to develop a tool, and we have developed actually a tool in Germany now, where for certain disease areas we are actually providing that navigator, kind of almost could call it a digital navigator in a way, where really the information that will be shown through that portal is being vetted information, being information that is trustworthy, no doubts, and people can trust that. And I think that is something, regardless of whether it comes from us or from other agencies or initiatives, I think that's a crucially important thing, especially now with AI and everything that comes along in our world. Every single day you look at the news and you see again something that was fake in one way or the other.
Oh yeah.
And of course that's also the case in when you talk about patient information, disease information, alternatives, etc.
I was going to say with alternatives, you have the people selling their version of an inverted commas cure for cancer. There are many of them, and they sound very tempting, and they will tell stories of someone who took it and did fine. That's not a study. And likewise, all the books, there are so many How I Beat Cancer books. And it's the and they're always written, or not always, sorry, that's wrong. They are often written from the, if you do what I did, you will be cured. And you cannot do that. I've deliberately not written a book about my journey for that reason. But again, so in terms of gaps, it's that site, as you say, digital signposting, reliable signposting, but also helping patients get to things like I mentioned the forum that I went on, which is still runs, and it's still a very good place for patients with colorectal cancer to go to in the UK. There are also on Facebook, there are lots of very good support groups, some run by charities, some run by individuals, but they're not all good. So actually you've got to find good ones. So signposting them to the very good Facebook groups. And there is so much to be gained from patient-to-patient communication in a safe forum.
Yeah, and safe environment, yeah.
Exactly. But all of it is, we should be signposting patients to these information points. I also have to say, I mean, I do a lot of work with several charities. A lot of the charities' websites are very difficult to navigate. Finding access to the right bit of information can be very hard. And so just saying to them, go to the charity website isn't always the right thing, always the best solo piece of advice.
So the charities might also need a little bit of a communication course in a way.
But help from good communication on how to revamp, absolutely. But your digital portal...
But to be honest, they are also most likely volunteers. A lot of them are volunteers trying to do their best. Yeah. And I think that is another point that I find particularly interesting, and that is, how can we, and we is a very broad term, help patient organizations, charities, with further professionalizing their own way, without, not talking about per se earning loads of money and stuff. That's not what I'm talking about. But like really, create more impact in a way, and be more supportive to the patients that they are representing, have more influence for the things that they are striving for in a way, towards agencies and so on and so forth. I think that is something that we should not underestimate, that the importance of that. And there are some really good examples in the world where really they really went into almost a full professional organization. And there are also examples where there are only like two persons trying to keep it alive with all their best efforts. So it's not about their efforts to do it, but they don't get to the next stage. And that is actually something that is not so good for that particular situation in that country than for that particular disease, what we're talking about.
Well, I set up Strive for 5 as a program, which is www.strive45.org. It's a not-for-profit. I actually, by not-for-profit, I pay for it all myself. And it is entirely around giving hope for people with stage 4 cancer.
It's a very important initiative.
But it shares just tips to get the most out of your chemo. It's approaches to things. It's some of the latest information, but it's deliberately done to be outside of the charity. So it doesn't tread on the toes of what any of them are doing.
Sure.
But it's a place that you can go to, and I've had so much feedback from patients where they said it's the first time they read something positive about stage 4 cancer, and so that's why. So I think this is important. But I've designed it. I designed it originally was just to tell the story of me getting to 5 years to give people hope. But I got such a response to it that it's become a program to give hope to people.
That's really fantastic, Steve, what you try to do there. It's an example for other cancers maybe, and other diseases actually, where maybe it's not the same kind of thing with Strive for 5, because that's really a cancer kind of thing, of course, but the same principle can be applied in other places as well, I think.
Hope so, yeah.
So say it again. What was the website?
Strive45. So it's FORFIVE, strive45.org. And we've got a presence on Facebook, Twitter, and Instagram as well.
I can't thank you enough for this wonderful conversation, and I think we had a script up front that we thought, hey, let's touch upon these points. I can tell you it was the other way around in the end, and that's perfectly fine. And I think it was an interesting conversation. Really gave me more insights into the journey, where you're coming from, your motivations, and some really insightful stories that you shared about communication and the gaps that need to be somehow solved, I would say, especially in cancer. Thank you very much once again, Steve, for being with us or with me in the podcast. Really appreciate it. And I might actually ask you to come back again and for a follow-up conversation. We could probably fill another 3/4 of an hour or something like that.
I'd love to. Thank you. I just hope it's interesting and useful for your listeners. Thank you.
Finally, I would also like to thank our listeners, and I hope this 6th episode was informative and inspirational. Please follow us on your favorite podcast platform and stay tuned for the next episode.